Hello everybody and welcome to this presentation on the management of feline chronic kidney disease in association with RCVS knowledge and their quality improvement stream. My name is Paul Pollard and I'm a first opinion practitioner working at the Royal Veterinary College in Camden, and I'm also in charge of student learning on the first opinion rotation. So let's start off with a very important question on quality improvement. What is quality improvement? What does it entail? And why should we be interested in it? Well, I've come across one definition, and this definition says that quality improvement is all about working together, gathering real information, and finding practical things that we can do to continuously improve as a whole. And I suppose that's why we're here, why we're listening to this webinar, and why we go to CPD, is that we want to gather real information from experts such as Sarah, who will be talking to us later on. And then we should be aiming to do something with this information so that we can continually improve, not just ourselves, but the practice team and the profession as a whole. And my learning objectives for this presentation are, at the end of the presentation, we should be able to understand the advantages of creating clinical guidelines to improve the standards to which we work. And also that we should be able to design a clinical guideline and clinically assess its value within the practice. So I'm going to hand over to Sarah now, who's going to give us some up-to-date thinking and some real knowledge and tips on the management of chronic kidney disease. And afterwards, I'm going to talk about how we can take this information and use it to drive quality improvement within the practice. Over to you, Sarah.
Thank you very much. And it's a pleasure to be able to still deliver this session in spite of the fact that, of course, we both very much were looking forward to delivering this as part of the RCVS Knowledge Stream at BSAVA Congress. And very sadly, that, of course, was cancelled due to the COVID-19 pandemic. And we're recording this in our own homes, but still very much would appreciate your feedback and comments and suggestions on the presentation, and very much hope that it's going to be something that you're going to enjoy and find a useful contribution to your CPD. So Paul kindly mentioned that I would be the sort of expert providing up-to-date information on feline chronic kidney disease. I'm an RCVS specialist in feline medicine, and CKD is most definitely a passion of mine. It's of course, a very important cause of illness in cats. It's estimated to affect at least a third of elderly cats, and therefore is something that we're very familiar with seeing in our clinics. And you will all know about the many repercussions that CKD has on our patient well-being. It's of course a great concern to cat owners as well. And thankfully, happily, it's an area of feline medicine where I feel there are constant advances being made in our ability to diagnose and also to manage CKD. And so for the purposes of this discussion today, really wanted to focus on what I think are the most important aspects of management, which is actually to provide dietary support for patients with chronic kidney disease. So a few conflict of interest statements to read there for you. The Vet Professionals logo on the bottom of the slide is mine. This is my own business that I set up, and does have a lot of educational resources which are free to access on the website, including in the video tutorial section some webinars for pet owners on chronic kidney disease, which you might find a useful resource to recommend to your clients. And as you'll see, my work does involve providing education and consultancy services for a number of companies with an involvement in the world of feline CKD and support thereof. So in our patients that we do diagnose CKD, what is the best way that we can help support these patients in terms of optimizing their quality of life and also importantly their length of life? And The true answer to this is that, and the reason I put several pictures of cats in is partly because I'm a very passionate believer that we should always individualize our healthcare to really titrate it to the individual pet and owner needs. But there are, of course, some overall strategies when it comes to CKD. And an important aspect of treatment is, where possible, to try and slow the progression of that disease. And chronic kidney disease is a disease which is always considered to be progressive. In other words, it will always get worse with time. And there are a number of reasons why that is the case. So-called maladaptive processes. These are compensatory mechanisms which are triggered as a result of the chronic kidney disease, which ultimately have deleterious consequences on the kidneys. And two good examples of these maladaptive processes that occur would be the renal secondary hyperparathyroidism, which arises due to phosphate retention associated with CKD. And secondly, glomerular hyperfiltration due to activation of the renin-angiotensin-aldosterone system, the RAS, which can result in damage to the kidneys and proteinuria as long-term consequences, which have an impact on further progression of disease. There are other factors that may well have an impact on progression of CKD and are known in other species, such as ourselves, to have an impact on progression of disease, and that would include things like systemic hypertension. But what I'm going to focus on in this presentation is one of those top two maladaptive processes which we know occur in cats with CKD, and also which we know we can have an impact on through our management, and actually the biggest impact in terms of improving patient quality and length of life through addressing the phosphate side of things, the phosphate story. So we'll just spend a few minutes reviewing what exactly is going on from a pathogenesis perspective in our patients with CKD. And as I've already mentioned, cats with CKD are very vulnerable to phosphate retention as a consequence of that disease. And that's because the kidneys are, in a normal, healthy individual, very important in regulating phosphate levels through excreting excess phosphate into the urine. But that excretory function obviously depends on healthy working kidneys, good glomerular filtration, and in a patient that does have loss or damage to their functional nephrons and actually has chronic kidney disease, they are immediately vulnerable to phosphate retention. The nephrons can no longer keep up with the workload that is required of them in terms of that phosphate excretion. And that has a number of consequences on the body, most important of which is triggering increased production and release of parathyroid hormone, PTH. And that, in the early stages of chronic kidney disease, may be helpful in terms of encouraging those remaining functional nephrons to work more efficiently to excrete phosphate, because parathyroid hormone is phosphatiduric. In other words, it encourages phosphate excretion by the nephrons. However, as the disease advances, those fewer numbers of functional nephrons just really struggle to keep up with the increased burden of workload on them. Forgive my anthropomorphism here. And so however much PTH is thrown at the kidneys, they just can't keep up with the need to excrete that phosphate. So phosphate levels do start to build up. And actually levels of or high levels of PTH also are quite damaging to our cats, both in terms of progression of disease, but also in terms of clinical signs associated with renal disease. So there's a number of things already you can see starting to happen, which are deleterious to our patient well-being and also to their long-term prognosis. And overall, as we get this phosphate retention, increased production and release of PTH, and this sort of vicious cycle that I've described, we then have this scenario of renal secondary hyperparathyroidism, also contributed to by the fact that kidneys are producing less calcitriol than would be normal for them. This is the active vitamin D, and that also contributes to development of the renal secondary hyperparathyroidism, and that as an entity is very damaging to our patient in terms of their clinical status. For example, we may see soft tissue mineralization, progression of renal disease, but also those high levels of PTH make our patients feel ill. So it's often PTH is considered to be a uremic toxin, and ultimately very detrimental to our patients' status and shortens their lifespan. And this is something that we've known about for many years now in cats with chronic kidney disease. And we also know that by addressing this, we can have a big impact on our patients and improve their quality of life and also their length of life. So the key to management in terms of this whole entity that I've been discussing is phosphate restriction, limiting the amount of phosphate that we feed our cats because we know that they're vulnerable to accumulating it. They can't excrete it as readily. And so titrating a bit more carefully how much phosphate they're offered. We do all need, our patients still do need phosphate. Phosphate is obviously part of cell membranes, energy transport systems within the cells. So phosphate is an essential nutrient, but what we're trying to do with these patients is really limit the amounts we give them to what is needed and minimize that possibility for phosphate accumulation and triggering of renal secondary hyperparathyroidism. And that's why organizations like IRIS, the International Renal Interest Society, that is an expert panel of nephrologists from around the world, have come up with some guidelines for also what blood phosphate levels should be considered normal in our patients with chronic kidney disease. And we should be aiming for them to be in the lower half of a standard reference range where possible, to try and remove any stimulus for production of parathyroid hormone. So the IRIS information is all very easy to access through the iris-kidney.com website referenced on this slide. And this table shows the different stages of CKD according to severity of azotemia, from the non-azotemic patient through to the patient with stage 4 severe renal azotemia. And that azotemia is categorized according to creatinine results in the third column. I've included the conventional and SI units for this. So in the UK, you'll be most familiar with looking at creatinine in micromoles per litre. And SDMA is a more recent addition to our ability to diagnose and assess severity of CKD as well. So patients with non-azotemic CKD may include those that have, for example, a structural abnormality in their kidneys, polycystic kidney disease or lymphoma, but they're not actually azotemic. We know they've got kidney disease, but it just isn't azotemic, versus those that obviously lower down the chart that have a varying degree of renal azotemia as identified here. And then in the right-hand column, you can see the target phosphate levels. So this is the IRIS guidelines that I was just referring to. A typical laboratory reference range might be between 1 and 2, or even 1 to 2.5 millimoles per litre. So it's quite a broad reference range. And the main thing to be aware of is that the reference range quoted by the laboratory is typically for that species, but includes all ages of animals through their life stage. And it is normal for young growing animals that are developing their muscle and bone to have quite high phosphate levels. So a kitten, it might be completely normal for their phosphate to be 2 or 2.5. But in a cat with CKD, we really want their phosphate much lower than that to try and remove any trigger to the development of this renal secondary hyperparathyroidism. So this is why IRIS came up with these guidelines. And you can see also that the target phosphate levels do differ according to the severity of CKD. So stage 1, we have up to 1.5 millimoles per litre, sorry, stage 1 and 2 up to 1.5 millimole per litre, but for stage 3 up to 1.6 and stage 4 1.9. Why is that? Well, it's not because actually we want the cats with the higher stage of CKD to have a higher phosphate, but we do have to be pragmatic and sensible in our expectations. And a cat with stage 4 CKD has very few functional nephrons. So realistically, if we can get that patient's phosphate levels below 1.9, we're doing a brilliant job. If we get it as low as 1.5, fabulous, but that may just be unrealistic expectations. So that's why the levels change. If at all possible, of course, less than 1.5 is ideal. And it is worth trying to keep these figures in mind in your clinic when you see your CKD patients. Many laboratories don't provide you with titrated guidelines on phosphate interpretation. It will just be part of the panel. And as I've mentioned before, the typical reference range will incorporate those young growing kittens as well. So you may need to actually interrogate your lab results a bit more thoroughly, because 1.9 phosphate could well be within the lab reference range and therefore not highlighted as abnormal unless you actually go and look for it. What are the aims of phosphate restriction? Well, of course, we want to switch off that renal secondary hyperparathyroidism, and where present, actually, it can be reversed. So, don't assume that once it's triggered, that's that. We can actually reverse it. But ultimately, this is because we want our patients to feel better. We want them to live longer. And this is going to be, we hope, the net benefits of our phosphate restriction. And the current IRIS recommendations are that all azotemic patients with chronic kidney disease have phosphate restriction as part of their regime, irrespective of their blood phosphate levels. So we don't look at those IRIS target levels in terms of deciding whether or not phosphate restriction is warranted. We assume they will benefit from it if they're azotemic. However, if we see, let's say, a stage 2 patient with CKD and their phosphate is 1.9, which is much higher than that stage 2 target, that gives us extra incentive, extra rationale, if you like, to increasing the phosphate restriction through measures I'll talk about in just a moment. So where is the evidence to support this? Well, there are quite a few papers that have been published over the years looking at the impact of phosphate restriction on survival statistics of cats with chronic kidney disease. The initial work was published from the Royal Veterinary College, Penny Barber and Jonathan Elliott, but there have been a number of studies since. So that the Ross study is an American study, and it's really been very widely accepted through expert consensus as well that this is very much a justified and important treatment for CKD. And the screenshot on the right here is a screenshot of a consensus of opinion guideline, which was produced by the International Society for Feline Medicine a few years ago. And this is an example of, I think, a really nice up-to-date reference which looked at the different interventions available for management of feline CKD and looked at the level of evidence available to support each of these interventions. And certainly for this consensus guidelines, the only treatment really which came out very, very strongly in terms of good evidence to suggest a really good impact was phosphate restriction. So it is something I feel we can really justify, and in fact probably all of you are already encouraging your owners of cats with CKD to feed a phosphate restricted diet. And that's the main way that we achieve phosphate restriction. I put at the top of this slide, maintain normal hydration, as it's just important to mention that a lot of cats with CKD are vulnerable to dehydration. And as soon as you are dehydrated, your kidney function really does plummet. And so if want our kidneys to do the best possible job that they can do, then maintaining and supporting normal hydration is, I think, an important strategy. So that might be talking to our clients about having multiple water bowls around the home, perhaps trying to make flavoured waters for the cat. So the sorts of things I talk about with clients would include poaching some chicken or some fish in a pan of water. We eat the chicken or the fish, or we feed it to an animal that doesn't have CKD, but that cooled down water, that sort of nicely flavoured infusion, might encourage the cat to drink more. And many cats don't have a very strong thirst reflex, and so they are vulnerable to dehydration as a species anyway, particularly when they get older. But CKD, of course, that's much more serious. So support hydration. Beyond that, really the main strategy is through reducing phosphate intake, and the most recommended route would be to use a therapeutic renal diet to achieve that, but dietary wise there are other options. So with the support of a veterinary nutritionist, a home prepared diet could be a good option. Senior diets tend to be moderately phosphate restricted. So if the cat won't eat the therapeutic diet, or the owner doesn't want to buy the therapeutic diet, a senior diet is likely to be a little bit in the right direction, and avoiding high phosphate foods to supplement the diet. So things like cheese, milk, meat are all quite high in phosphate. And then the second strategy, which also can be very helpful in combination with a phosphate restricted diet or separately with a normal cat food, is to use an oral phosphate binder, a substance which binds to phosphate within the food and prevents it from being absorbed, so that that phosphate is passed out in the feces rather than going into the cat. Therapeutic renal diets are the most proven management strategy for CKD as far as the available publications show. And in general, cats that have CKD, if they will eat a therapeutic renal diet, they will tend to live 2 to 3 times longer than if they were eating a standard supermarket cat food, for example. Also some nice evidence in some of these publications in terms of improved quality of life. So it's not just a long-term strategy, it's actually hopefully going to make your cat feel better in the short term, perhaps reduce some of the clinical signs that have been present in that cat, whether that's vomiting, nausea, or other problems. And these therapeutic renal diets have a number of modifications in addition to the phosphate restriction, which may also be of value, which is why they tend to be more prioritized compared to just phosphate restriction alone. Although it's fair to say we've not done the level of detailed research that you would need to sort of unpick the specific benefits of the other modifications. But these, the commercial therapeutic renal diets tend to be designed to be as palatable as possible, also often calorie dense. So in other words, a cat that has a poor appetite, if it just has a few mouthfuls of a therapeutic diet, is going to take in a lot more calories than if it were just going to take a few mouthfuls of supermarket cat food, for example. Protein restriction, really the main benefit of that is to potentially reduce uremic clinical signs associated with buildup of protein breakdown products. Non-acidifying, so less likely that our patient will develop a metabolic acidosis, which can make them feel quite ill, and supplemented with the sorts of things that cats with CKD are vulnerable to having low levels of through excess loss in the urine, so hypokalemia, vitamin deficiencies potentially catered for there, and low in sodium to hopefully reduce the risk of systemic hypertension from developing. But the main benefit really thought to be the phosphate restriction. Most of the benefits in terms of the publications have tended to be orientated around azotemic cats with kidney disease, so IRIS stage 2, 3 and 4. And there's often a lot of discussion really as to, with the cats in the earlier stages or the milder stages of CKD, whether there are benefits to changing diet at that point, or whether the main rationale should be along monitoring the cats and owner education and support as appropriate. And the book picture there is a book that is available through my website, which is aimed at owners of cats with kidney disease and explaining the condition and hopefully reinforcing the recommendations that come through the vet clinic. Within the last few years, there has been a little bit more data come through to support some phosphate restriction of cats in IRIS stage 1 CKD. And the screenshot you can see now is from a study that was performed by Hills, so performed by a nutritional company, where they looked at some client-owned elderly cats, and one cohort of these cats received a senior type formulation of food, which was a Hills product, so not KD, but a sort of senior diet, versus a more standard adult maintenance cat diet. And they demonstrated through this study that the cats that were on the more phosphate restricted diet, their renal disease appeared to stay stable for longer when tracking their creatinine and SGMA levels. So there may be some rationale for these early renal diets in some of these cases where perhaps it's difficult to justify the full-blown, if you like, therapeutic diet, or perhaps there may be worries that the protein content in that therapeutic renal diet is perhaps too restricted for a cat in IRIS stage 1 disease. These are cats where maybe a senior diet or a moderately phosphate restricted diet, which some pet food companies are now producing, is indicated. I mentioned this consensus guidelines a little bit earlier, screenshot again on the slide, but if you do look at that publication, and it is free to download, you don't need to be a member of ISFM or to subscribe to the Journal of Feline Medicine and Surgery to get this publication. But if you do look at it, you'll see that there are some color-coded boxes within that publication for each of the interventions in terms of the quality of evidence and also the panel's recommendations. And I've just lifted out really a summary version of that in terms of therapeutic renal diets for this slide. And you can see that the quality of evidence of therapeutic renal diets as an intervention is considered to be good in terms of increasing lifespan and improving quality of life. And that's why this is a strong recommendation of the panel. Ideally, that patients are fed exclusively a therapeutic renal diet, if possible, wet rather than dry, just because these cats are vulnerable to dehydration. But a dry therapeutic diet is better than other supermarket diets, for example. So the emphasis on the therapeutic renal diet as the first important step. What level of compliance is realistic? Well, it has varied a lot if you look through the literature. Some studies have shown really quite high levels of compliance. So the top, you can see research studies relating to CKD up to 94%. Probably worth pointing out that often in those studies where they had really good compliance, the food was provided free of charge as part of signing up to the study, as part of being recruited. And so that I think is actually worthwhile knowing, though, because what it says to me is that if you remove a barrier to the owner, which is perhaps cost and perhaps effort in terms of sourcing the diet, but if you just give them the food, there's a good chance they're going to do a really good job in feeding it to their cat because you've provided it to them. So it is also, to me, demonstrates that good compliance is often possible. And so if we see a lower compliance, and you can see right at the bottom, therapeutic diets in general from pet owner surveys, often 10 or 20%, that there are reasons in there that are not just limited to the cat and the acceptance, but likely involve the owner as well in terms of their enthusiasm to try this, perhaps them being persuaded that it is the right strategy and it's really important. So education and support also comes into this. What are my tips for successful transition? Well, I think it can be quite daunting for owners. A diagnosis of CKD in itself is often quite stressful to owners. And even though, in my opinion now, many cats with CKD will live a very long period of time following diagnosis, often several years, still as a diagnosis, it can be quite an emotional roller coaster for carers. And as part of our ongoing plan, I think the main message messages we want to support are that, firstly, this is a long-term aim, and don't worry if you can't succeed in 1 week or 2 weeks. If it takes 6 months, but you succeed, that is still brilliant, and that's worth going for. And every effort you make to move in that right direction is going to be doing good things as far as the kidneys are concerned. If possible, introduce a diet early in terms of when the cat is relatively well. Cats with stage 4 renal disease are probably going to feel quite sick, and maybe much harder to persuade them to eat a different cat food. But typically it does require a lot of perseverance as well. And so I would always say to my owners, do expect to be throwing out a lot of food unless you've got conveniently a Labrador in the house that you don't mind hoovering up the uneaten kidney food. It is unfortunately inevitable that you're not going to have 100% success in terms of dietary transition, because this is often quite challenging. From a clinical perspective, also resist the temptation to introduce a new renal diet at the point of diagnosis with a sick cat in the hospital, because whilst it may eat that new diet in the hospital, often cats will eat things in the hospital that they would never eat at home anyway, but also they may associate that new different diet with, oh, I was in the vet clinic then, I felt ill, it was horrible, I was really unhappy, and although I ate it then, I'm just, it's obviously poison because it was given by those people there. So try to wait till the cat is at home, wait till the cat's in the best possible shape otherwise, so sort out anything else that needs sorting like dehydration, and then gradually start to introduce it. And wet, prefer to dry for the reasons we've already talked about, and ideally therapeutic renal diet. But if that's not possible, the sort of flow chart in that penultimate bullet. So a home prepared diet with input from a nutritionist where available, then a senior diet, and then lastly, a more standard commercial cat food. I do think we as clinicians do have a power to really influence the behaviour of our clients, and this was illustrated to me with respect to CKD in an owner survey that I published a few years ago. Vet Professionals hosts a number of surveys, primarily with pet owners, and this was one that we wanted to understand owner experience of phosphate restriction in their cat with CKD. And as part of that survey, to which, as you can see, 859 owners responded to this survey, owners of cats with kidney disease, we asked a question. Firstly, had anyone recommended feeding a therapeutic renal diet to their cat with kidney disease? And about 90% of the owners said yes, they had received that recommendation, which is absolutely brilliant in terms of a good reflection of veterinary world making that recommendation. About 10% of them said no, and I think it's quite possible that some of that 10% did receive the recommendation, but perhaps they didn't remember it. But in any case, that was our starting point. And then, as you can see, those that were aware they'd received that recommendation, someone had said to them this is important, you can see from our survey 72% of the owners were feeding at least some therapeutic renal diet to their cat with CKD, versus 7% of the owners who'd not received that recommendation. And the only reason that it's 7% and not 0 is because the sort of people who fill in surveys on my website, as you might imagine, are really dedicated owners. So obviously these 7%, they hadn't had that recommendation, but nonetheless, they'd gone off and done some reading about CKD, perhaps bought my book, and decided off their own bat that they were going to go down this route. But for me, a big take-home message for this really was, in terms of overall impact on patients, is we not only need to make this recommendation, but we need to reinforce it. We need to make sure that our owners are really aware that this is an important recommendation as part of their cat's management. Phosphate binders, I briefly mentioned a little bit earlier, are substances that we can give to bind phosphate in the food and prevent phosphate from being absorbed into the cat. So they're sort of doing a lot of the phosphate restriction that might be present in a therapeutic renal diet, but just in a slightly different way. And you'll know there are a number of these available on the market, and they can be used with standard cat food, or they can be used with therapeutic diets. They take a while to have an impact on blood phosphate levels, because all they're doing is reducing the amount of phosphate that can be absorbed with the food. And a key thing really is that they need to be given with the food, either in the food itself or very close to a mealtime, to have an impact. So they're particularly useful in those situations where, for whatever reason, either the cat or the owner can't be transitioned to that renal diet. Perhaps the cat has other health issues which have a different dietary priority, for example. Also in those situations where phosphate levels remain high in spite of that transition to a renal diet. In my owner survey, one of the questions we asked was for owner tips for acceptance of phosphate binders. I did think this was actually a really useful thing to ask and get data on. And you can see some really sensible recommendations on here in terms of starting at a low dose, gradually increase, mixing it thoroughly, perhaps disguising with a little bit of something nice. And I particularly like the bottom recommendation, which I do think is completely and utterly valid. But cats are, you know, they can be quite clever creatures. They know when we're behaving differently. They start to suspect us when they see us behaving strangely, and that can affect their likelihood of eating that food as well. So I think take all of these tips and use them in your clinics, and hopefully that will help. The consensus guidelines, their view on phosphate binders is that there is much less data to stringently assess the impact of these as an intervention. However, based on what we know about phosphate restricted diets and what we know about what's going on in the phosphate story in the cat, it is considered that they are likely to have a good impact in terms of slowing the progression of renal disease, and therefore they are a sensible intervention if a therapeutic diet can't be used, or if a therapeutic diet on its own is insufficient to help manage our patients with renal disease. Many cats with renal disease, of course, are also quite difficult to transition onto a new food because they feel ill. And so it's worth always looking at that individual patient and trying to determine what barriers might be present that are affecting this cat's uptake of the food, and what we can help with. So for example, there are some things on the list on the left that we can very definitely help with. If our cat is dehydrated, we can correct that. If our cat has hypokalemia, we can correct that. If a patient's anemic, we can also support that. If they have chronic pain due to, for example, osteoarthritis, we can support that as well. So I think always within our individual, try and think as critically as possible what potentially might be going on in this patient that I can help with, and that is likely to have a positive impact on dietary acceptance and compliance to that therapeutic renal diet. So going down this sort of checklist to make sure we've crossed off possibilities like dehydration, electrolyte imbalance, anemia, as discussed. There are some really good treatments available for nausea and vomiting. Meropitant is obviously a licensed treatment. Mirtazapine is not veterinary licensed, but is available and is a really good appetite stimulant in cats, and also in cats with kidney disease has that added advantage of having some antiemetic effects. In cats with CKD, I tend to start at the lower dose, 1 milligram per cat every 48 hours, and there are tablet formulations, and there are also transdermal formulations of mirtazapine available to help support. Pain relief, depending on the patient, if it has osteoarthritis, well, meloxicam can be tolerated by many cats with CKD if they're not dehydrated and if their disease is stable. But if you're worried about non-steroidals in certain patients, then other painkillers like buprenorphine might be indicated. So it's about looking at the patient, seeing what might fit with their clinical presentation and might improve their likelihood of complying with the diet that we've chosen. And again, looking at the data for managing inappetence, nausea and vomiting from the ISFM consensus guidelines, there's no data that this is going to help our cat with CKD to live any longer. However, it's likely that they will have a better quality of life if they're symptomatic with any of these clinical signs. And therefore, we should be looking for it and managing it to the best of our ability. And current consensus would be also that mirtazapine is a good product because it attacks both the nausea, vomiting, and is appetite stimulating as well. So if you're not already using that in your patients, I think it's a very helpful product to have available. Other tips for owners and also for cats in the hospital. Cats always like to eat little and often, so try not to overwhelm them with food. Any uneaten food, take it away. If this is in the hospital, if it's not been eaten within an hour or so, probably take it away. And resist the temptation for what I refer to here as the buffet. This is where very well-intentioned owners and perhaps nursing staff may think, well, what have I got in my house or in my hospital that might be delicious to a cat that's not feeling very well, and then basically offering all of that simultaneously. So we've got the sort of sardines and the pilchards and the tuna and the prawn and the chicken, and it just is too much, and that can trigger a food aversion where the intense aromas and sight of food in combination with the cat feeling ill just makes the cat associate the two, and therefore anything food related becomes a negative for that cat, and it will often need tube feeding and no food offered voluntarily for some time to actually recover. Some other general tips on here in terms of the sort of food bowls that cats tend to like. So they tend not to prefer plastic given a choice. They don't like their whiskers touching the sides given a choice. They like privacy. They like calm, quiet environment to eat. They might appreciate hand feeding. If they're elderly and have arthritis affecting their elbows and their shoulders, they might appreciate the food bowl being lifted up, just placed on an upturned bowl, for example. If they've got dental disease, they might appreciate the food being mashed a bit. Things like catnip. Some cats also fortiflora can make the food appear more appetizing, and not doing stressful things close to a mealtime. So try to avoid dosing the cat with whatever medication it needs at the same time as a mealtime, unless you absolutely have to. So there's a lot of different things to consider in CKD which all can have an impact, and as I mentioned right at the start, I think it's the individualized approach that is going to really optimize the outcome, looking at that individual cat and owner situation and working out, well, what treatments really are going to make them the best result for this situation. But in terms of overall management of CKD, I think the key messages are, in terms of slowing progression of disease, phosphate restriction has to be an absolute essential, and often can be practically achieved with our patients at home. Suppression of the renin-angiotensin-aldosterone system, the RAS, is something I've not talked about, but you will be aware of through use of medications like ACE inhibitors and angiotensin receptor blockers, is also an important consideration, especially for patients that where there is evidence of RAS activation manifested through proteinuria, for example, that we hope that also will have, if we treat those patients with RAS suppressing therapy, that we'll be able to improve their long-term outcome. And then very importantly for the individual, it's the additional symptomatic and supportive treatment that really makes their life worth living on a day-to-day basis. So reducing nausea, increasing appetite, and so on. And I'll just finish off with a case study which hopefully illustrates some of these challenges. This is a cat called Sula, who I first became involved with when she was 12 years old. She's a female neutered domestic short hair, and she had a background history of having previously had a healthy weight of around about 4.5 kilos. She'd had some dental issues in the past which had been treated. Then you can see during 2016, she'd had some senior health checks in February and October where things had looked quite good. You can see she's got very dedicated owners. They're bringing her in for these senior health checks, which is great. Her systolic blood pressure, that point 138, which is normal. That's great. Urine specific gravity, quite good, 1045. So that is concentrated urine. Then in 2017, her urine specific gravity, it's come down. It's now sitting on that sort of borderline of normal to abnormal. We consider a USG in a cat of less than 1035 to be abnormal. Her blood work was still okay, and in fact her weight okay at that point. She had a dental in July, but then in August she was found to have on evaluation increased creatinine. Her USG was the same, and a therapeutic renal diet was initiated at that point, prescribed at that point to support that CKD that had been identified. And over the following months, that was when the symptoms really started to show from her owner's perspective. And really the main manifestation was appetite falling off. And she'd now, having been previous healthy weight of 4.5 kilos, the weight was really starting to fall off her. So you can see by the October, her weight had dropped to 4.2 kilos. The following January, she was 3.7 kilos. And compared to her healthy weight, that to 20% loss of her body weight, which is of course absolutely massive. Her owners said that Sula was preferring the wet food to the dry food, but that her appetite even for the wet food was poor. They also reported some changes to her feces. They would just seem to be quite loose a lot of the time. Her renal parameters actually appeared stable, so IRIS stage 2 to 3. She was not proteinuric or hypertensive, and phosphate levels, reasonably okay, pretty much at those IRIS targets. And the only other slight concern on assessment in the January was that her calcium levels were either at the top of the reference range or just a little bit above, depending on which reference range you use. So that concern over possibly a mild hypercalcemia. So the main concern, of course, here is really her appetite. In terms of thinking through how to support Sula at this point, there were a number of concerns she'd come with in addition to that poor appetite, namely the fact she had this loose feces, what was going on there. Also that fact that the calcium was just a little bit elevated. Was that something that was hinting at other concerns or concerns that we needed to address? So a number of questions really at this point in Sula's story as far as deciding where to go next. But from a kidney disease perspective, as I've mentioned already, my starting point would be to think, well, what can we find that's fixable, that is likely to be having an impact on her appetite, but we can help her with. And also from an appetite perspective, opening up the differential diagnoses to consider other possibilities, because she is an older cat and many older cats have more than one issue. From a symptomatic perspective, options also at this point, which we can have in our mind, would include, well, we can use an appetite stimulant, something like mirtazapine that I've already mentioned, and see what impact that has. We also potentially can try a pure antiemetic approach, something like meropitant, which obviously is licensed, to see whether nausea is a cause of that poor appetite, even if vomiting is not reported. We can give some guidelines guidelines in terms of that dietary support, the nursing care aspect for the owners. We can also look more closely at exactly what she's eating, and in terms of calorie access, perhaps try and focus on more calorie dense therapeutic diets, and always I guess have on the list the possibility of more active nutritional support, for instance tube feeding. So what happened with Sula? Well, we had some good discussions on this an initial day that we met up, and in terms of proceeding, there was clear enthusiasm on their part really to do some investigations where we could learn a bit more about her kidney disease, investigate that calcium in a bit more detail, and really, screen a bit more thoroughly for other possibilities. And we would have gone ahead on that day, except for that our calcium analyzer for ionized calcium was actually out of reagents. So from a practical perspective, we decided, well, rather than having her in and just, doing 90% of what we wanted to do, we'd send her home with some symptomatic treatment and have her back at a later date to do a thorough investigation all on the same day, including some imaging of her kidneys as well, to see whether there was any structural clues as to underlying ongoing illnesses that might impact on her appetite as well. So I provided them with some mirtazapine at a low dose, that 1 milligram dose every other day, so every 48 hours. We discussed some nursing care, appetite support. I also advised them to try a phosphate binder with the non-therapeutic renal diet that she was receiving, so it gave them a bit more flexibility of what they could offer. And we arranged to speak a week later and find out how things were going. And at that point, her owners were actually quite happy to report that her appetite definitely had improved on the mirtazapine, and they were quite content with how things were going. So meanwhile, of course, we still wanted to do the investigations that we had planned. And so that actually ended up happening 3 weeks after the first appointment, at which point you can see she'd gained actually quite a large amount of weight for a cat, 0.45 kilos gained in 3 weeks. So quite a dramatic uptick in her weight, really just as a result of the mirtazapine and nursing support and a bit more flexibility with what she was being offered following our discussions. Her lab results at that point were relatively similar in terms of her creatinine and STMA, in terms of her stability of her renal disease. Phosphate just a little bit higher than I would ideally like it to be. Potassium a very fractionally lower than I would like it to be, but really not dramatic. As you can see, calcium not on there because that was all turned out to be fine in terms of total and ionized results. Her urine specific gravity a little bit lower, her thyroid looking okay, she's not proteinuric. We did, as you can see, some GI related tests as well, which all seem to be fine. And on imaging, no sort of really earth-shattering findings in terms of any unwanted surprises, should we say. Kidneys, both certainly looking a little bit less normal on imaging than a healthy cat's kidneys were, so a reduction in corticomedullary definition, the left kidney smaller than the right, but nothing, as I say, earth-shattering in terms of our diagnostics. Some thickening of the small intestine diffusely, so perhaps consistent with diffuse GI disease, whether that was inflammatory or diffuse neoplastic, undetermined at this stage. But the weight gain, extremely good to see as a positive change with very, very little intervention. So what's the assessment at this point? Well, really seemed to be, based on our investigations and the response to treatment that we got, that the most likely scenario was that her poor appetite was related to her CKD and the usual challenges really with a new diet, not so popular. Her owners very keen for her to eat the therapeutic renal diet, so had been fairly rigidly sticking to it, which on the one hand is wonderful, but obviously with her not really having a good appetite, that did contribute to her fairly rapid weight loss. But we've been able to turn that around. No other complications at this point from a renal perspective. The loose feces at this point, not really the cause of that, not clear. We've got a few possibilities still left to consider there, but really good response to symptomatic support. So the plan really at that point was to continue with that supportive approach and monitor things. And her treatment at this point included some potassium supplements. So she had some Caminox for that. The phosphate binder that we chose was Renate. And that she seemed to take quite well, starting again at homeopathic doses and gradually building up as per the owner recommendations I showed with you a little bit earlier. Mirtazapine for appetite support, and really the only additional challenge that her owners reported was that tablets they did find quite tricky. So were there other options we could consider there? And in fact, as I've mentioned earlier on, there is a transdermal, or there are some transdermal preparations of mirtazapine available as obviously not licensed in the UK, but they are available through some specials labs such as Summit, Bova and PCCA. In the US, so if you are an overseas delegate listening to this, then you may be able to access Mirataz, which is a licensed veterinary mirtazapine transdermal, which is available in the United States. And so we did talk about this as an option. Transdermal mirtazapine, there are a few publications on. Jessica Quimby has reported in one of these studies, actually looking at cats with chronic kidney disease, and found that the transdermal formulation she was using, which I think was made it wasn't the licensed Mirataz, it was before that was licensed, I think it was made at the university pharmacy, did have a statistically significant impact on appetite and weight. And you can see at even relatively conservative doses. Often with transdermal medications, you need to use a higher dose than is given orally, but actually with mirtazapine, it's the same dose that is recommended as orally. So 1 to 2 milligrams per cat, 2 milligrams per cat being a standard dose. But as I say, I would, in cats with kidney disease, tend to start on 1 milligram per cat, because you can always up the dose if you need to. If you've not used mirtazapine before, it's worth knowing that in terms of adverse effects, probably the most common one is for cats to be very vocal and a little bit agitated on mirtazapine. So the owners will typically report, if that's the case, oh yeah, the cat ate, but then it just wouldn't sit still. It followed me around the house. It was meowing at me constantly. It wouldn't, it wouldn't sit down. It wouldn't chill out. So a little bit distressing for them to witness that. It does of course wear off as the drug wears off, but that is one reason I will personally start at a 1 milligram per cat dose for cats with kidney disease, and also always give it no more frequently than every 48 hours in a cat with CKD. They need a little bit more time between doses because of their kidney disease, and you can always up to the 2 milligram dose if you need to. So Sula's long-term progress has been really good. Her owners, I already mentioned, they're very dedicated, very keen owners. Well, I encourage them to consider monitoring Sula's weight at home, which is often a recommendation I make to owners of cats with CKD if they are keen to be involved, because you can get relatively inexpensive scales from the likes of Amazon, etc. And I also said it'd be useful to monitor just exactly what are you feeding Sula, how much is she eating. And I didn't provide them with a table. They designed this table themselves. You can see it's very detailed, really week by week, documenting how much she's eating, how much of that is renal compared to non-renal food. You can see she, for the duration of this chart here, was on a mixture of renal and sensitivity control. Her body weight, whether that's going up or down. So a huge amount of data that's being collected, and is absolutely brilliant in terms of monitoring progress, and therefore allowing us to see, well, how are our interventions working, and do we need to make further changes? And I last spoke to her owners end of January of this year. Sula's continuing to do really well. Her renal disease remains pretty stable in terms of renal parameters. Her soft stool has been the main thing that actually has concerned her owners recently, whilst it's not had an impact on her otherwise. So I don't think it's likely to be anything terrible going on in there. It's been a focus for us in terms of tweaking her diet and seeing if we can really get an improvement in her stool consistency that would be appreciated by her owners. But she is really well in herself, and her body weight also doing really well. So a nice example of where we can really have a big impact. CKD is obviously an unpleasant disease. It's a progressive disease. It ultimately is likely to be the cause of Sula's demise. And yet, through some involvement in her care and with obviously a great deal of support from her owners as well, we've been able to really improve her clinical condition and quality of life. And that's been very rewarding to see. So there are some useful resources that I've just referred to with respect to CKD, and some I've already mentioned. My website also shown on here, and I mentioned in the video tutorials earlier on there are some owner webinars on CKD which your owners may find helpful to refer to as well, and of course the book that I wrote for cat owners as well. So thank you very much for choosing to listen to this webinar. I'm going to hand back to Paul now for the next section of the webinar, where he's going to talk about how you can make changes in your clinic and hopefully support your owners. Thank you.
Thanks very much, Sarah. That was an excellent presentation, very, very informative, and some really great tips that we can all take home with us. I know I've recently diagnosed kidney disease on my own cat Tom, so I've been busily scribbling some notes down that I'm going to, sit and have a think about and use over the coming weeks, months, and hopefully years. And I'm sure everybody else who's been listening has been scribbling down notes, and maybe if you're very high-tech, taking screenshots of the presentation. But it begs the question, what next? We all go to CPD, and over the years I've been going to CPD with my little notepad and scribbling down notes, and whatever happens to those notes, or what do we do with them? Does it stay in our Congress bag until we need the Congress bag, or what do we do with them? And I remember reading or seeing somewhere a while ago about the definition of good CPD and what exactly is good CPD. And I love this definition because it rings true with all the best CPD that I've ever been to, because good CPD is not just about what you hear, it's about what you do as a result of what you hear. And I always think that if I go to CPD and I go to listen to a webinar and I scribble down some notes, and at the end of it, I really, really enjoyed it, and I don't do anything with those notes, well then I would argue that I've been entertained. But if I actually take those notes and I change what I do and I take them back to practice and I do something differently, then I've been educated, and that is the beginning of quality improvement. So with that in mind, I would, if this was live, I would be asking everybody in the audience just to have a think about all the notes that they've taken and what they've written down, and just pick one point that Sarah has given us. And I know that there's multiple ones there, but the one that rings true, or the one that you think is the most relevant one to you, if there's one thing that you've learned today, what is it? And just think about, okay, what is the main take-home message that you've taken from that wonderful webinar among the multiple ones? So for me, if there's one thing that I'm going to take home, it's this slide, and I love this slide, the aims of phosphate restriction. And there's a number of reasons why I love it, because it's very, very simple. It tells us the reason why renal diets are very important in cats. But if we think about it in even more detail, it's brilliant because it hits values on 3 different levels. And these values may be clients' values, or they may be our own professional values. In other words, it can make our patients feel better. So some clients aren't really worried about, how long their cat's going to live. They just want to know, is my cat okay and what is my cat feeling? Whereas other clients will want their pets to live forever. And if you can convince them that phosphate restriction is that important, that it will significantly increase the life expectancy of their pet. If you talk to them about that value, well, then they might be more inclined to use the diet. And again, other people just might feel helpless and say, well, are you not going to give it any medication? Is there nothing that you can do to help with this disease? If you try to get across, well, actually, you know what, phosphate restriction can slow down the rate of disease progression, well, then people may be interested in that. And of course, some people will be interested in all 3 of these aims. So I particularly love this slide because it lets us know about all the important things that phosphate restriction can do. So the one thing that I have learned really is that I have learned that phosphate restriction is very important in the management of renal disease. And if I take that thought and say, well, okay, phosphate restriction is very important, well, what am I going to do differently whenever I go back into practice? So in other words, what is going to turn this from good CPD into great CPD? How am I going to do something differently that is going to change what I do rather than just having something written down on a piece of paper? Well, whenever I go back into practice, I'm going to recommend renal diets for all my renal patients and explain the benefits to the clients. And the reason why I'm going to explain the benefits to the clients is because different clients may have different values. And if I explain all the benefits, well, then we may get better compliance. And I thought that was very interesting whenever Sarah was talking about compliance. It could be that some people, whenever the benefits were being explained to the clients, that the person that explained the benefit didn't hit the value that the owner was most interested in. So what I'm going to do is I'm going to recommend renal diets for all my renal patients and explain the benefits to my clients. But I don't think we go far enough for that, because CPD is very important and quality improvement is very important. And you know what? CPD can be very expensive. So I have to think about, is there anything else that I can do in order to get the maximum benefit out of CPD? And this is where I've come up with this thought about the CPD pyramid. So I'm just going to explain a little bit about what the CPD pyramid is. At the bottom of the CPD pyramid is us going to CPD and coming away with knowing. And what we do is we write things down on our notepads or iPads or whatever, and we go away knowing more. But if we go back to the previous definition of good CPD, well, then technically just knowing more doesn't change how we work. So I would argue that it isn't real CPD. The way we get good quality CPD is if we do something differently. So the next level up on the CPD pyramid really is taking what Sarah has said and then going away and changing something with how we work. And if we use the example that I gave, the next level up would be me recommending renal diets to all my kidney patients and trying to convince clients of the benefits of it. But again, I don't think that is good enough, because there's no point in me doing that if all my colleagues within the practice don't do it. So the next level up the CPD pyramid really is taking that concept and embedding it within the culture of the practice. And the way I feel that is best done is to create a clinical guideline. And we'll speak more about clinical guidelines later on. But if we create a clinical guideline which explains the benefits of phosphate restriction and renal diets and embed that within the culture of the practice, well, then we've got so much more out of our CPD than scribbling some notes on a notepad. And then the final part of the CPD pyramid and the top of it is if we extrapolate that concept of sharing our CPD experience, sharing our notes, writing clinical guidelines and tweaking clinical guidelines across other disciplines, well, then I think that's how we get the most out of our CPD. So what next? We've decided that we are going to take all this information back to the practice, and we've agreed that we've learned something and we're going to make a change within the practice, and we're going to think about writing a clinical guideline, because that's the next step. Write a clinical guideline. But I suppose we have to ask ourselves, why bother? Really, what is the point in putting something down on a page and going to the hassle of writing a clinical guideline when we can just tell everybody within the practice that you've went to some CPD and you've learned some stuff, and what we should do is we should encourage phosphate restriction, or one of the other interesting points that Sarah said, there were so many of them. So why bother with a clinical guideline? And I think it's a really great question. And in order to prepare for this talk, I decided, well, do we need to create a clinical guideline? So what I decided to do is I decided to ask some of our receptionists and some of our nurses within a first opinion teaching hospital, why do we feed a renal diet? And these are some of the answers some of the team came up with. One reception says, I don't know. I don't know why we feed a renal diet. And that's disappointing, because often receptionists are the ones who are talking to clients about which food to feed and what to do. So I think it's disappointing that the receptionist didn't know why we're feeding a renal diet. Another person said, well, it's kinder to the kidneys. Somebody else, it slows down the disease. And again, if you take that concept, it slows down the disease, they are correct. They are 100% correct. It does slow down the disease. But if this person or this nurse was talking to an owner who was interested in how their cat felt and was it making their cat feel better, and they only presented this information, well, then that client may not have been overly interested in slowing down the disease, especially if the cat wasn't interested in the diet, so therefore they may not have made the switch. Another person said it is less protein, and somebody else said it isn't that tasty. And then whenever I asked the next person, they said, well, actually it is, it's tastier than other foods. And again, it just shows you that there's a lot of people have a different understanding on this simple concept of why do we feed a renal diet. And with that in mind, I think it means that creating a guideline for something like this would be very, very useful. And finally, somebody else said, again, I don't know, but I just know that you can't feed it to sick cats if they're not eating. And again, they're correct with that, in that we don't offer it to animals in the hospital, but that's not really the reason why we feed a renal diet. We feed a renal diet for the reasons that Sarah has mentioned. So I think clinical guidelines certainly have their place, and there's a number of reasons why we should create clinical guidelines, especially for renal disease, because renal disease is a very complex and progressive disease. So giving some guidelines or some guidance to our team will certainly help with those situations that they may run into that they're not familiar with. And again, for phosphate restrictions, it makes a patient feel better, they live longer, and it will slow the disease progression. Clinical guidelines are also an excellent source of reference. And again, this is particularly useful if you've got a big team and there's a turnover of your team members and somebody else comes in and they want to know, well, what does your practice do in this case? Well, then you can offer them access to the clinical guidelines where they will be able to get up to speed as to what your practice recommends. Clinical guidelines are a guide to best practice, and I think this is very important, because what we want to do is we want to push the standards with which we as individual practice, but equally with the standards to which the team practices. And one way of doing that is to create a guideline that everybody agrees to make sure that you're not just recording what you currently do, but what you aspire to do based on evidence that we get from the experts such as Sarah, or from webinars and congresses. So clinical guidelines should increase our clinical standards. And of course, clinical guidelines should be reviewed and adjusted with changing opinion, because The more we learn, our opinions can change, so it is, and new drugs can come along, new tests can come along. So it's important that we review our clinical guidelines on a regular basis so that we can keep them up to date. So how to write a clinical guideline. And I appreciate there's a lot of information here, and I'm going to whiz through it very, very quickly, but there's some tips about how to write a clinical guideline. And the first thing that we need to do is we need to pick a topic. And I suppose my advice here would be, if you haven't written a clinical guideline before, well, then you should keep it really, really simple. So rather than writing a guideline on the management of renal disease, write a clinical guideline on how to introduce a renal diet to cats with renal disease, or how to write a guideline for monitoring renal disease. How often do you monitor it? Whenever you've picked a topic, the next thing is to try and gather a team and do some research. And this is a vitally important step, because if you get this wrong, well, then the rest of the process doesn't work. You need a team that is going to be engaged in the subject matter. And nurses are invaluable in this. You have to really think about what are the roles of the nurses with the clinical guideline and get them involved whenever you can. And of course, speak to reception as well, because if the clinical guideline is something such as recommending a renal diet, then the reception team should have an input. And ownership of the guideline is very, very important, and we should have what is known as a bottom-up approach. And what I mean by a bottom-up approach is that the clinical guideline should be written by the members of the team that are going to be implementing and using the clinical guideline. So my recommendation would be to get the nurses and the clinicians on the floor to write the clinical guideline and then present it to management to see whether management are happy with it, rather than management writing a clinical guideline and then trying to get the team to implement it. It works better if you get buy-in and ownership for the members of the team that are actually going to be using the guideline. Supply references. References are very, very important. And I know Sarah has mentioned some earlier, and I'm going to mention the similar ones later on. But references are very, very useful, because if anybody questions anything in the guideline, or you're not really sure where the science has come from, supplying references is just useful so that you can look it up very, very quickly. And whenever you've written your guideline and you've got a draft of it there, I think it's important that you release it to a few members of the team and ask for feedback, in case there's something within that that just doesn't make sense to them if they don't understand it, or if there's something that is incorrect. I don't think there's anything worse than you spending a lot of time and effort creating a work of art to launch it, only to get an email pinged back straight away saying that somebody has noticed a flaw in it. So release it, ask some of your colleagues to review it, get some feedback. And then whenever you've got that, pick a launch date and a launch time and launch it to the team, explain the rationale behind it, and let them know that there's going to be a review date. And again, that review date is very important, because if the clinical guideline isn't working for whatever reason, it gives you a chance just to sit down and have a rethink and fine tune it. And the final thing as part of writing a clinical guideline is to undertake a process audit. And I'll talk a little bit about that later on, because I've just recently done a process audit in our hospital, and that is very, very important. And there's some great learning in undertaking a process audit. Now, the good news is you don't have to remember any of the stuff that I've just said. You don't have to write anything down or take a screenshot or anything like that, because all the information that you will ever need on how to write a clinical guideline is on the RCVS Knowledge website. And if you can't remember the address at the top of the web bar, if you just Google RCVS Knowledge, it'll come up there. And there's useful CPD course for 20 minutes, which will walk you through the guideline process. There's some templates there. There's some consensus statements as well, which can act as a source of information for you to write your guideline. So it's a really useful first step, and everything you need to know to write your first guideline should be supplied there. So have a look. And again, as far as good places to look for information, if you're going to tackle renal disease, ISFM consensus statement, as Sarah mentioned, is free to download. The ARIS website, another excellent resource. Again, Sarah's website, Vet Professionals, have a look at that. And again, the RCVS Knowledge website is packed with some information. So again, have a look and start the process of writing a guideline. So we've decided we're going to write a guideline. We've got the key members of our team ready. We've got some nurse involvement and some receptionist input as well. We've done our research. We've gone to the ISFM consensus statements and IRIS website and RCVS knowledge. And now the next step is to create a guideline to fit your practice. And this is where I struggle a little bit, because there's something fundamentally wrong in me sitting here telling you how to write a guideline to fit your practice. Because the first thing about writing a guideline is it should be a guideline for your practice, not for my practice or someone else's practice. Because a guideline should be specifically designed to take a look at what is available with regards to resources and equipment and what fits in with your clients. For example, I was recently reviewing some guidelines for a charity practice, and whenever I was reading through their guidelines were, and it had to do with heart disease, their guidelines were fundamentally different to our guidelines, purely because in a charity practice, their budgets and their resources would have been completely different. So it's wrong for me to tell you what guideline I would use for your practice, but it is very right for you to sit down and write that guideline yourself. And there's another fundamental flaw in me telling you how to write a guideline, and it has to do with educational theory. So let me see if I can explain this a little bit better than just waffling. Let's start off by this person. I'm going to ask, and I know nobody's going to know the answer to this, but does anybody know who this man is? And if I was doing this live, I'd be asking for a show of hands, and I'd be fairly confident that there would be probably nobody in the audience who would know who this man is. But this man has done an awful lot of research, and this research is very, very crucial to guidelines and what we're talking about here. And it's world-leading research. And this gentleman probably doesn't know what a guideline is. I'm pretty sure he doesn't know anything about chronic renal disease in cats, and he may not even have a cat. So how does his research tell us so much about writing guidelines? Well, this gentleman is an educational psychologist called John Biggs, and he has written some fantastic research. And one of the things that John Biggs says is that learning is constructed by what activities the students carry out. Learning is about what they do, not what we teachers do. So what that means from a clinical guideline point of view is you are not going to learn how to write a clinical guideline by listening to me telling you how to write a clinical guideline. The only way that you're going to learn how to write a clinical guideline, the only way that you're going to get the most benefit out of Sarah's CPD and get it implemented within the practice is actually by sitting down and starting the process of writing a guideline. And I say the best thing to do is to go to the RCVS Knowledge website and click on that and walk through the process. It is very, very simple. But this webinar would be very, very short if I just said, well, look, just go and do it. There are a few tips that we can give you. So let's see if there's some tips that we can give you. So whenever I've written guidelines in the past, there's a few things that I've learned. The first thing that I've learned, it is very important to write a clinical guideline, and it also takes a lot of time to do it. And this time needs to be protected, and this time needs to be designated. So it's not really something that you can do in your lunch hour. It's not really something that you can do on top of your already busy schedule. This is something that you need to go and speak to your boss, present a business case to them and say, look, I really need some time to write a guideline on this topic because it is very, very important. And in order to convince your boss and in order to convince your team members as to why a guideline is important, you really have to know what the values are of your team members. So in other words, if your team member is very, very keen to work to a better standard and produce or to practice better quality medicine, well then convincing them that the guideline will do that will enable it to take place. Guidelines are very, very good at making us practice good quality veterinary medicine, And whenever we practice good quality veterinary medicine, well, then we generate more income as a result of it. So if you can convince your boss that there will be a financial bonus to writing guidelines and practicing better quality medicine, well, then you may get the time allocated. And of course, it will also drive animal welfare as well, which is very important. You have to get buy-in from the team. If you don't get buy-in from the team, well, then it's not going to work. So make sure that you get people involved in creating the guideline. Make sure those people are the ones that are going to help you implement it. Team education is very important. And it's very important that if you can give people statistics and give people examples of why a guideline is going to work, give examples of why, as Sarah said, phosphate restriction is important, then whenever you can give them examples and educate them, then the guideline is more likely to get embedded. And the final thing, again, I've learned this recently, is whenever you release a guideline into the practice and say, this is great, everybody take a look at it and please do this, that's really only the start of the process rather than the end of the process. You have to follow it up. You have to keep looking at it to make sure that it is embedded and that people are using the guideline, using a process audit, and ask the team for feedback rather than just releasing it and hoping that it works. And I'll give an example of that later on. So things to consider. So if we are writing a guideline, I think I've already mentioned this, keep it simple. That is the key. If you release a 14-page document covering a whole lot of different whys and whatnots and wherefores, it's just not going to take off. You need it to be really, really simple, and the simpler the better. The simpler it is, the more likely it is to get embedded, and then whenever people realize that guidelines are simple and they do have positive results, then they're more likely to be accepted, and your next one will be a little bit easier. If we're talking about renal diets and say, well, what can I do to ensure that my clients are using renal diets? Well, again, have a follow-up phone call. Give them a phone call in a week's time just to touch base with them to make sure that that they're getting on. See if you can just go over the tips and hints that you would have talked to them about, just to make sure that they're sticking to it and compliance is better. Every practice management system should have a reminder set up. So again, if you diagnose renal disease and you talk to your clients about renal food, create a reminder just so that you can touch base with them just to make sure that compliance is good. Whenever you're getting these cats in for your consult, again, make that important question in your history taking. It shouldn't all be about weighing them and how's your cat feeling and have you noticed anything different. Diet should be really, really important. Asking them how the cats are getting on with the diet. Encourage your clients, give them options and know their values. A lot of clients have found over the years that if you ask closed questions, is your cat vaccinated? The answer will be yes. Or are you giving the tablets? The answer will be yes, because clients don't want to disappoint. They don't want to come across as being bad clients. So if you ask them, are you feeding the diet? The answer will probably be yes. So have a little bit of empathy towards the clients and see if you can understand them a little bit more. Ask open questions. Can you tell me about Fluffy's diet? And then listen, rather than, are you managing okay with the diet? Which is a very, very closed question. And again, audit your process, reflect and adjust, and consider benchmarking. Benchmarking is another useful tool to see how many of these patients 6 months down the line are still being fed renal diet, or whatever benchmarking tool you want to use. And again, I love these two slides that Sarah came up with, her top tips for the acceptance of phosphate binders, appetite support tips for owners. They're fantastic. And if you look through these very, very quickly, they are the basis of a guideline. There's no reason why these can't be used as a source for an excellent guideline that you can take back into your practice and start using immediately. And again, some people may not like the words clinical guidelines, but there's no reason why you can't say, okay, we're going to have top tips for compliance on renal diets, or whatever wording you want to use. And this is the reason why it is important to adapt it for your practice rather than me telling you what you should do. So quality improvement, how can we quality improve? And here is a real life example, and this is to do with one that I've introduced maybe about 3-4 months ago, and it isn't to do with renal diets or kidney disease. It has to do with heart disease in cats. And we introduced this guideline into the practice a few months ago. And the reason why we introduced it is because my interest is in cardiology, and we were getting a lot of older cats coming in with heart murmurs. So we decided to introduce a guideline, and this isn't the full guideline. This is just a very, very truncated, just for illustration. But the guideline, in very, very simple terms, was if a murmur was noted in an older cat, we should always recommend an echo so that we can find out what the state of the cat's heart is and how much underlying heart disease there is. Recommending an echo just isn't good enough. We found that we also have to give a handout explaining the importance of sleeping respiration rate and respiration effort for the owner, so the owner would monitor this at home. And the handout will also explain a little bit about the disease process and why their cat may be asymptomatic and the importance of that, and equally how an echo works. So what I did was I created this guideline. I got some feedback from my colleagues. I put in some case examples. Tom, my cat, has heart disease as well. So I put him in, and the reason why we did an echo on him is because he was drinking more. We took some bloods, his kidney values were high, and so we knew he had kidney disease. And he also had a little murmur, so we decided to do a heart scan, and of course his left atrium is massive, so we had to take a look at that as well and put him on some clopidogrel. So we decided to write a guideline for heart murmurs, and then a few months down the line we decided to process audit. I took a look at all the cats who had been seen over the past few months who were 10 years or older, looked at the clinical notes and asked, and then checked to see whether a murmur was noted. So the first one that I looked at was an 11-year-old cat presented for a health check. On cardiac auscultation, there was a grade 2 out of 6 heart murmur was heard, and this was the first time it was noted. And then whenever I read the clinical notes, this clinician said that they discussed the heart murmur. They recommended for the owner to monitor sleeping respiration rate and effort at home. A handout was given, and the advice was for the owner was to call back in with some respiration rate values, and at that stage the owner was going to consider an echo. And whenever I read this, I thought, that's brilliant. We have just introduced a guideline, we have just implemented quality improvement, and things are wonderful. And it just proves that guidelines work. So then I continued to look at some of the other notes that were made for older cats. And again, I was getting this with a lot of the other cases that were seen. But equally, I got some of this as well. So we had a 10-year-old cat with a murmur, and the clinical notes didn't discuss or recommend anything with regards to the murmur to the client, but a handout was given. The next one, a 12-year-old cat, was in for a health check. A murmur was detected, and a dental was needed. And again, no handout was given to this client. So again, are we going to do dentistry in an older cat with a heart murmur without checking for heart disease? The next one was a 9-year-old cat with breathing issues with a grade 1 murmur. And again, no handout or recommendation was made. And then the final one, a 19-year-old cat with a heart murmur and a gallop rhythm. And no handout was given, and no discussion in the clinical notes as to why this was the case. And it just begs the question, in the 19-year-old cat, was the owner not interested in investigating, or was the vet not interested in investigating? And whenever I audited the clinicians that were involved in these cases, these clinicians were more surgical based rather than medicine based. And again, that's something that we need to bear in mind, that we have to try to convince these clinicians as to the importance of investigating these cats with heart murmurs. And then the final one, which I thought was very, very interesting, was a second opinion 14-year-old cat who presented. It was very, very unwell. It had an arrhythmia with some dropped beats, and it also had breathing issues. It had laboured breathing, and there was certainly an inspiratory effort. And after discussion with the owner, they opted not to investigate, and it was put to sleep. And then whenever I saw this, I opened up the clinical records for the primary care vet who the client had seen recently, and the history at this vet's were 4 months previously the cat presented. Its mucous membranes were pink and moist. CRT was less than 2 seconds. There was no skin tent, but they did notice that it did have a 2 out of 6 heart murmur. Its abdomen was comfortable on palpation, and it had a sore leg and was treated with pain relief. And it just makes me wonder whether this sore leg, could it have been a microthrombus, or if this animal had an echo at this stage, was there anything that could have been done? And again, it just shows you that these cats are being missed in our practices and other practices. And if we can get this guideline in place, it's certainly going to drive quality improvement, which is what we're all about. And I think this is my final slide, just to let everybody know that all these resources are on the RCVS Knowledge website. There are some templates for you to walk through. There are some real case studies for you to download, to read. There are some great articles and opinion pieces, and there are some podcasts as well. And this is my final slide. In summary, in order to write a guideline, gather a team, do some reading. Come up with a plan and give it a go. Keep it simple. Reassess it in a few months and then tweak it if it isn't going according to plan. And finally, remember that good CPD isn't defined by what you hear. It is what you do as a result of what you hear. So please take your clinical notes, go away and make some changes. Thank you for listening.